or rectocele. We can do rectal examination بس ما لقيتش أي شيء مكتوب عنها بالكتاب اللي أخذت منه الكاس.
We don't usually do rectal examination for rectocele. You don't have to go through it.
Yes.
So let's just stop for a point. Would you go back one step, please?
Yes.
Okay. So the main category of this presentation, genital pelvic organ prolapse, this is usually restricted to female patients usually. Males do not have pelvic organ prolapses unless you consider rectal prolapse to be one of those pelvic organ prolapses. So in general, what should we focus about whenever we ask a lady and when concerned with pelvic organ prolapse? What are the main issues we should focus upon during our history, our interview? Of course, this is for all of you.
Yeah.
For 1 second, this is for all of you. And please raise your hand before you speak so that we don't all speak at the same time, so they can listen to each other. Okay, Bayan, go ahead.
الشايلد بيرث والمينوبوز وكمان أي شيء بيزيد الانترا ابدومينال بريشر زي الكونستيبيشن كرونيك كاف أو سموكينج. يعني هذول من الكيس اللي عندنا. بس في كمان إذا كانت عاملة بالفيك سيرجري زي هيستريكتومي أو ريشال فاريانت زي الكوكيجيان عندهم they are more at more risk, higher risk.
Okay, fair enough. Hassan, are there any other issues you'd like to ask her about, this lady?
Yes, دكتوري. بهتم بالايج لانه يعني زي ما احنا شايفين البيشنت 83 فممكن by aging الكولاجين وهيك اشياء ممكن يصير عندها يعني مشكله.
We're not discussing the theory in this case. We're discussing what should we go about asking this lady. So let's presume the scenario. An 83-year-old lady comes to you to your clinic, your GP, and she tells you, I've been complaining over prolapsing vaginal mass for the past few years, but since for the last year, it's been unbearable. Okay? Let's just keep it to this extent of information. This is usually what will be presented to you in the exam. You'll be given some information, but not everything. In your exam, you should not ask again about the information you've been given, but you should allude further about the other symptoms. So what should we ask her about, this lady?
ممكن أسألها دكتور عن urinary symptoms إذا عندها urinary symptoms.
Such as? What do you mean by urinary symptoms?
يعني incontinence أو
okay.
يعني
incontinence. Okay, you'll ask her about incontinence. What else?
Voiding difficulty ممكن.
Okay, fair enough. Anything else? Anyone else has any further questions they'd like to ask this lady? Okay. So your main focus will be تفضل.
ممكن نسألها if she's incompleting مثلا emptying her bowel مثلا.
Okay. So how would you ask her this question?
بسألها يعني straightforward question.
يعني
if she enters the bathroom and doesn't complete the process of defecation ممكن.
So in general, what you'd like to ask such a lady with this presentation. So her main complaint is a prolapsing vaginal mass. Yes, you will ask her since when did it start? You already know for a few years. How did it progress? When is it worse? Is it exacerbating, for instance, by standing? Does it increase when she coughs, laughs, goes up the stairs, stands up? Does it reduce when she lays back on her back, for instance? Does she have urinary or bowels rectal symptoms? By urinary symptoms, we're mainly focusing about urinary incontinence. And if she does report that she indeed does have urinary incontinence, we should ask her, what type of incontinence? So how can we differentiate between types of incontinence? Usually, by history, of course. Or let's go a step back. How many types of incontinence are there in the first place? Amir? تفضل. Amir. Okay. We're going step by step. Hassan, كمان مرة رافع إيده.
Yes, doctor. We have 4 types of urinary incontinence. مثل stress incontinence والurge incontinence وفي overflow incontinence وفي fourth type I forget the names صراحة.
So in general, we have stress, we have urge, we have overflow, and we have total. You're correct. Stress is whenever the intra-abdominal pressure increases, it will overcome this resistance by the urethral sphincters, and you'll leak urine. Urge is whenever there is usually a problem with the detrusor muscle itself, either the detrusor muscle itself or its neurological control, and then you'll start leaking urine spontaneously due to detrusor contractions. Overflow is whenever the amount of urine accumulates enough to increase the pressure within the detrusor muscle to cause a leak of urine. And total, whenever the patient does not feel the sensation to urinate in the first place and they keep leaking all the urine they accumulate. That's usually due to a problem with the sphincter itself. Overflow is usually to a problem. It's the opposite of total incontinence. So the problem with the sphincter could either that the sphincter does not contract, or it's lacerated or injured for one reason or another, and it will cause total incontinence. Or on the other hand, it could be that the sphincter is restricted, or the bladder neck, for instance, in males, you could have prostatic hyperplasia, which will occlude the outflow of urine, and only when the pressure within the detrusor muscle is higher than the restriction to the outflow, you'll leak some urine. So these are the types. So how can we differentiate between those? Of course, the main differentiating factor is usually history, not examination, not investigation. In most cases of urinary problems, that's how we differentiate in gynecology. So how can we differentiate? Hassan, again.
Yes, دكتور. بالنسبة للstress incontinence بيكون يعني involuntary loss of urine.
Okay, that's incontinence by definition. It's always involuntary.
Yes, this increased with يعني abdominal pressure, مثلا coughing or laughing or sneezing.
Okay.
This is for
so
stress.
We try to identify the exacerbating factors. Fair enough. What else?
Me also,
anyone?
Doctor?
No, anyone. It's not directed against. Just raise your hand, anyone, and we'll go through it. So, in stress incontinence, as you, Hassan?
Doctor, I would like to talk about urge incontinence.
Okay, go ahead.
Yes, بيكون في sudden urge to void, Doctor.
Okay, so I'll just go over the general descriptives, how usually patients present whenever they have any of these complaints. So when it's stress, usually there's identifiable exacerbating factors, such as cough, laugh. Whenever the patient coughs or laughs, goes up the stairs, stands up from spine to rectus, so anything that increases the intra-abdominal pressure. Okay, and she'll leak urine. Usually the amount of leak is slightly significant, so a good amount of leakage of urine, and it's not associated with other issues. In regards to urge, usually there's the identifying factors are the patient, there's a special descriptive, they call it the key lock or the bathroom sign. So whenever the patient will suddenly have an urge to void, that's why it's called urge. But by the time she reaches the restroom or the water cycle, she will leak a minimal amount of urine. In regards to urge, there will also be usually identifiable risk factors, such as any disease that might cause neurological disease, such as MS, diabetes, history of pelvic surgery that might damage the neurons in that area, trauma, especially to the spine. There'll also be there might be increased caffeine intake, alcohol intake, methylxanthine intake, and so on. Usual urge is associated with nocturia, sometimes even nocturial enuresis. So stress and urge are the ones we're going to be focusing about in regards to pelvic organ prolapses, because these are the ones that are associated with pelvic organ prolapses and gynecology in general. So what else should we ask her about? After asking about whether does she have incontinence in general, and if there is, we analyze when does it happen, how much does she leak, does she have sudden urge, and so on. And if she does have indeed nocturnal enuresis, and of course, whenever there is incontinence, you should ask about the other lower urinary tract symptoms, especially dysuria, because it might be caused by a UTI. What else should we ask her about, this lady? What should we try to identify in her history? Okay, Hassan again.
دكتور حضرتك حكيت ممكن نسألها specifically عن ال UTI symptoms وكمان ممكن أسألها عن ال vaginal delivery مثلا كم كانوا
What would you ask her specifically about vaginal delivery? So you'll ask her about birth weights. Okay, what else?
Yes.
Anything else?
Doctor, we ask if the vaginal delivery
بس لأن عمر رافع إيده قبلك فبدنا ناخذ عمر. أنت ما رفعت إيدك. هاخذ عمر بعديها برجع لك. عامر عفوا. Why are you concerned with vaginal discharges? Procedential. It's not quite a significant question to ask a lady with such a complaint about vaginal discharges, frankly. I promise you it will not be part of your exam to ask her about vaginal discharges. So the doctor that speak before, if she has anything to tell us. Okay. Are there any other questions? تفضلي سماح.
Doctor, regarding the vaginal deliveries, we need also to ask her if the vaginal delivery is assisted with instruments or if it was prolonged, because that also increased the risk.
We'd like to know if anything caused trauma to the lower pelvis, whether it's the muscles or the ligaments. So in regards to her obstetric history, we'd like to know how many times did she give birth in the first place? What's the weights of the babies? How did the birth process go through? Was it complicated? Did it take a long time? Did they need to use an instrument? Did she have anal sphincter injuries? These all will increase the likelihood of damage or trauma to the neurons and to the ligaments and to the muscles in the pelvis, which will increase the risk of pelvic organ prolapses. So someone else actually raised their hand and they lowered it immediately. Did they have anything to tell us? Okay. So بيان تفضلي.
ممكن نسألها كمان إذا في عندها previous prolapse.
We would, but for your exam, it would not be part of the history because we're already going to ask her, did she undergo any pelvic surgeries before? So you should ask her if she will tell you if she did undergo pelvic prolapse surgeries from before. Any other questions? Okay, someone talked about pain. Yes, we will ask her about pain, but what's the normal descriptive of pain associated with pelvic organ prolapse? How would the patient describe to you pelvic organ prolapse associated pain? Does anyone have a clue? Hassan?
Doctor, if this patient was يعني younger than this age, ممكن نسألها عن مثلا pain during the intercourse or something like that.
is pelvic organ prolapse is usually not associated with dyspareunia. Okay, it's associated with something opposite of dyspareunia, almost exact opposite of dyspareunia. Do you know what I'm going to talk about next? Any guesses?
اللي هو الأبيرانيا دكتور.
Yes, there'll be sexual dissatisfaction from both partners usually, especially if there is a widened perineum. So the lady will tell you she's having more difficulty achieving orgasm, and so will the husband or the spouse or the significant other tell you that they're having problems achieving orgasm. This is usually due to the widened perineum and inability to contract the perineal muscles. Now, the next issue we should ask her about is rectal dysfunction. Usually, especially if there is a posterior compartment herniation, otherwise called rectocele, the patient will tell you that she is having what we call obstructed defecation. So obstructed defecation, when there is a mechanical obstruction to the rectum, the patient will feel that she has incomplete emptying of her rectum, or there's a typical description is that she splits her vagina. When we talk about splitting of the vagina, is that the patient will try using her fingers to reduce the prolapsing mass so that she can defecate in the first place. Usually the stool will be of narrow caliber in this case, just like rectal cancer, because that's the same pathology, the same physiology that's occurring in this case. So anyone has any other questions, ask this lady that he considers relevant for this case. Okay, so I presume these are the most important questions to ask this lady. What's next? It's examination. So what should we do in regards to examination in this lady? What are our main focuses in examining this lady? Okay, Samah again.
We need to inspect the vulva during cough or sneezing.
Okay. We should try to be systematic and go step by step. So before we reach the vulva, what should we do? What should we do? Samah again. Should you raise your hand again?
Doctor, maybe the general examination, if you mean by that, the blood pressure and the vital signs.
Okay, we always do general exam, but what's more specific in this case after general exam? And what's the main aspect of general examination you would like to tell me about in this case, for instance? Hassan, is there anything else you'd like to add? Go ahead.
ممكن بالexamination عشان حضرتك حكيت to be systematic ممكن أشوف إذا في مثل laceration أو atrophy بالskin أو شيء زي هيك.
No, that's not what I was hinting about. Anything else? So, in regards to general exam, I'd like to know her BMI first, because high BMI is a risk factor for pelvic organ prolapse, because there are two considerations in regards to high BMI. First is that obese patients have higher intra-abdominal pressure by effect of the weight of adipose tissue in the abdominal wall. Second is that obese patients do not just have increased fat within their subcutaneous tissue. They usually have high fat infiltration within the muscles. And this increase in fat within the muscles will make their muscles weaker in the first place. And next, what should I do after general exam? We should palpate the abdomen. حسن يوسف أو حسان رح أضلني أخربط فتحملوني طول ما كلكم كاتبين دبل اس. تفضل.
كنت بدي أحكي إنه يس abdominal examination نشوف إذا في any previous scars. نعمل palpation لليوترس نشوف tender أو في اتونيا أو
Correct, but I'm focusing about the main issues here, just like you're expected to do in your exam. So our main aspect here, we're trying to figure out, is there anything that's increasing the intra-abdominal pressure, i.e. masses? Also, if the patient has generalized weakness of their connective tissue, you might expect them to have other types of hernias, because pelvic organ prolapse, by definition, is a herniation. It's a hernia. So if their ligaments are weak, their fascias are weak, they could be weak everywhere. But our main issue here is palpating the abdomen for any masses or if the uterus is enlarged. Then we'll go for pelvic examination. And in pelvic examination, what should we do? What should we do in our pelvic exam? Again, راح أناديك باسم عيلتك جبر أو جابر.
يس دكتور، اسمه حسان يوسف جبر، مش مشكلة.
بعرف، بس راح أضلني أنسى لأنكم كاتبين 2 دبل اس، فمش راح أتذكر.
مش مشكلة دكتور. أكيد دكتور، بنعمل أول إشي انسبكشن للفالفا، ونعمل سبيكيولم اكزامينيشن، بنشوف إذا في أي prolapsing، وبنخلي البيشنت مثلا تعمل coughing or sneezing.
Okay.
تمام.
Good enough. So when we do examine the pelvis, the first thing I would do is that I would expect the perineum. My main focus is to figure out, is the perineum excessively wide or not? That's one. Number two, I'd like to figure out where her perineal body is, because usually if the perineal body is wide, that means there is some sort of deficiency in the perineal body in the first place. And that's a risk factor for pelvic organ prolapse. Afterwards, I'll inspect the vestibule and go with the sim speculum, retracting every vaginal wall while asking the patient to strain or cough to try to inspect where the prolapsing mass is arising from, which part of the uterine wall, and how can we go about approaching these. How can we classify or how can we grade the pelvic organ prolapses? Does anyone know? Is there a system by which we classify pelvic organ prolapses? سواهرة منك أول واحد رفعت.
Yes دكتور. I think في system بقسموا اللي يعني into 4 grading من 0 to 4.
شو اسمه السيستم؟ في أي حدا بيان تعرفي اسمه؟
في البادن ووكر وفي الشوز. البادن ووكر بيعتمد على الهايمن بحسب إذا وصلت للليفل of the hymen or not، والشوز على الانترويتس، يعني إنه in the vagina stage 1 reach the introitus هاي stage 2 و stage 3 بتكون يعني prolapse يعني
معظم الدنيا ما بيستخدموا الاثنين، ومش رح تلاقيهم بكتابك، مش رح تلاقوهم بالكتب لأنهم قدام. شو بيستخدموا آخر 20 سنة إلهم؟ في أي حدا مر عليه؟
في واحد اسمه pelvic organ prolapse quantification هذا.
Yes, POP-Q, pelvic organ prolapse quantification system. So that's how we actually try, because that's a uniform quantitative rather than qualitative classification of pelvic organ prolapses, and we use it to classify the prolapse to different stages from 0 to 4. 0 meaning no prolapse, 4 meaning there is complete eversion of the vagina, otherwise called, if it's apical prolapse, prosidential. Okay, so we're done with interviewing this patient and we examined her. What should we do next? Does anyone have any clues on what should we do next? Okay, sorry, just one sec. Hassan, Jabbar, Hassan?
Can you use a link of the vagina?
Well, that you will do during your speculum exam. So that's how the POP-Q actually works. So just give me a moment so that I show you the POP-Q in the first place. Of course, you're not expected to know how to use POP-Q. You're just expected to know that there is something called POP-Q. Okay, what's the problem? Okay, Bayan, I'm gonna take control. Please close your stop sharing so that I can take control for a brief moment.
طلع دكتور البورد.
بس عندي مش عم بطلع. اوكي هلا بلش. Work with this screen. Okay. So this is a diagram to show what POP-Q is. So first in POP-Q, there are three distances that are important, which is the genital hiatus, the GH, the perineal body, as we talked about before, and the total vaginal length. The total vaginal length is the distance between the hymen and the apex of the posterior vaginal fornix. And then there are 4 points. The posterior point of the hymen, the anterior point of the hymen, the anterior cervical lip, and the posterior the posterior vaginal fornix. And we grade how far do these points descend close to the hymen. And accordingly, we have certain method, certain numbers that classify what type of prolapse do we have, or what grade of prolapse do we have. Now, how many types of vaginal organ prolapses do we have, or pelvic organ prolapses do we have? Does anyone know? Just give me a moment. I'm gonna do something so that I can see actually who's speaking. Okay, here we go. عامر تفضل. We're talking about vaginal prolapse. Cystocele and urethrocoele are categorized to be the same. So other than cystocele, does anyone have other suggestions in regards to pelvic organ prolapse, vaginal pelvic organ prolapses? Layan?
في rectocele دكتور.
Okay, there's rectocele.
Anterocele.
Anterocele. So these are the different vaginal prolapses. So I'm gonna try to draw. I know I suck at drawing, but bear with me. Let's just skip all this. I'm gonna go down for a moment. Okay. So, as we said before, there are three main types of vaginal prolapses. Either you'll have cystocele. During cystocele, what we call the pubocervical fascia, which is the fascia on the anterior vaginal wall, has a defect. And due to this defect, the whole vagina will prolapse inward along with the bladder. And thus it's called cystocele, because the bladder is prolapsing as another vesicle. In the posterior prolapse, the defect is usually in what we call the rectovaginal fascia, which is the fascia on the posterior vaginal wall. So the whole rectum can prolapse into the vagina, which is the lower part, and then we call it rectocele, or the small bowel can prolapse into the upper part of the vagina, and we call it enterocele. So it's a type of herniation. It's due to weakness of the pubocervical fascia or the rectovaginal fascia, firstly and rectovaginal fascia. Sorry, the pubocervical fascia, the anterior part, is called cystocele. If it's in the posterior part, it's either lower, and we call it rectocele, or upper, and we call it enterocele. Entero, because of the small bowel, and rectal, because of the rectum, of course. Also, we could have what we call apical prolapse. Apical prolapse is usually the uterus, if it's present, or the vaginal vault, if the lady had previous hysterectomy. So, what should we do next? After we know the different types of prolapse, we have a lady. We suspect she might be having pelvic organ prolapse. She's 83, and she comes to our clinic with nothing but pelvic organ prolapse. Of course, there's something we forgot to talk about previously, is that pelvic organ prolapses usually present with chronic, deep, dragging, lower abdominal pain. That means that the lady will feel some heaviness or something dragging on her back whenever she stands up or strains. That will give us a hint there is something stretching the ligaments of the pelvis, by the way. So what should we do next? After physical examination. Layan again.
دكتور إذا already خلص إنه تشخصت, maybe we start talking about the management with her.
Okay, that's one solution. So if you don't have any abdominal masses that you felt during your examination, and if she does not have any urinary symptoms, we can proceed to treatments. How would you treat this lady? What are the possible treatments for this lady? Hassan?
Yes, doctor. Surgery.
What type of surgeries? What do we call these surgeries?
دكتور في anterior or posterior something بس يعني ما بعرف بالضبط يعني ما طلعت عنهم بس.
بيان؟
دكتور بالأول ممكن يعني تتريت ال provoking factors إذا كانت obese أو إذا كان عندها constipation أو إذا كانت smoking.
Okay, so we start with lifestyle modification first by trying to remove the modifiable risk factors for pelvic organ prolapse, whether it's chronic cough, constipation, smoking, or BMI. Of course, this is unlikely to happen in an 83-year-old lady. So what else can we do? Layan?
دكتور بالأول we have to discuss with the patient if she wants like a curative surgery إنه تماما surgical approach أو في management يعني ب non-surgical approaches.
And always in medicine, you start from the least conservative measures when applicable to the more invasive methods when applicable. So here we start with the least invasive. We start with the lifestyle modification by removing the exacerbating factors or the risk factors. What else can we do conservatively to manage pelvic organ prolapse? تفضل حسن.
دكتور ممكن نعالج حسب إذا البيشنت بدها اليوترس ولا لا، يعني مثلا ممكن بلش في بيسريز مثلا.
قبل البيسريز.
للبيسري ممكن كول برافي مثلا.
قبل ليان.
دكتور في exercises عشان يقوي muscles والligaments.
Okay, so we do pelvic floor exercises. In pelvic floor exercises, first, during our examination, we ask the lady to try to contract her pelvic floor muscles, and we feel that she actually is able to contract her pelvic floor muscles. If she is indeed able to contract her pelvic floor muscles, there are certain exercises we ask her to contract her pelvic floor muscle at least 10 times, 10 repeats, 3 to 4 times a day. And then we reevaluate her in 3 to 6 weeks to figure out did her symptoms improve or not. Please remember that managing pelvic organ prolapses is sort of like managing fibroids and endometriosis. We're not managing the disease itself, we're trying to manage the symptoms of the disease. We're trying to improve the quality of life rather than removing the pathology, because the pathology is not a malignant pathology, it's a benign pathology. The whole goal of this treatment is to improve the quality of life. So we don't have to reverse a grade 3 prolapse to a grade 0. You can improve it by reducing grade 3 prolapse to grade 2, and then the lady's asymptomatic, and that's good enough for us. We don't need to do anything else. So let's presume we tried conservative measures and it failed. What can we do next? Hassan, again.
Yes دكتور، كنت بس I would comment على الميديكال كمان. قرأت إنه هلا إنه مرات بيستخدم silicone rubber ring something like that.
اللي حكى عنها زميلك البيسريز.
اوكي نفس اوكي تمام. وممكن دكتور if she's in her reproductive age ممكن يعني to advise her مثلا to delay any يعني مثلا IDs for being pregnant يعني for the next يعني period.
في أي حد عنده اقتراح تاني قبل ما أعلق على هاي المواضيع؟ سماح؟
لا دكتور، كنت رافعة من قبل، كنت أحكي عن السيرجريز بس.
Okay, so in conservative measures so far, we've discussed that we can ask her to reduce her weight, stop smoking, treat her the cause of her cough if it's present, treat her constipation if it's present, and so on. In regards to other factors, that's physiotherapy, as in pelvic floor exercises. We try to induce contractions in the pelvic floor muscles and at least 10 times a day for at least 4 repeats, if that is applicable. The issue that your colleague discussed, just give me a moment. Are pessaries. Pessaries are celastic tubes or celastic curves. I don't know. Sorry, I'm just gonna try to take this upward. Pessaries are rings that will try to induce a shelf in the upper part of the vagina to try to reduce the prolapse that's already occurring. Usually pessaries are better for apical prolapses, and they will help us reduce an obstruction conservatively. Now, the problem with pessaries is that they're usually bothersome. So that's how pessary works. All it does is that it supports, let's change the color, it supports the upper vaginal fornices and this sacrospinous ligament and the pubic bone to try to prevent any further prolapse. Now, pessaries, the problem with pessaries is that you have to change them frequently, between every 6 weeks to every 12 weeks. They can cause erosions, they can cause infections because they're a foreign object that's inserted there for a long duration of time. And most ladies do not use them. Usually we reserve pessaries for patients whom are not candidate for surgeries, or when we're considering surgery, but not very soon. So we temporarily use pessaries for this case. Pessaries, of course, come in different sizes and different shapes. Usually they're just donut shaped. So they're a ring that's usually white, if the picture comes in your exam. If that all fails, we have to go for surgery. So what are the types of surgeries? One second, because I lowered your screen. Okay, Hassan.
دكتور هلا definitive treatment يعني إذا كانت البيشنت ما بدها أصلا تخلف وكانت old age نعمل hysterectomy. وإذا كان
I'll stop you for a moment. Hysterectomy is not for vaginal prolapse. It does not work for vaginal prolapse. It works for uterine prolapse.
Yes.
Okay. We're talking about vaginal prolapses.
Yes. Sorry. We can do colporaphy or colporaphy bixi.
Okay, we can do colporaphy. And what are the different types of colporaphy? Because you have to know their names for the sake of your exam. Okay, Hassan?
Yes, doctor. في عندنا posterior والanterior colporaphy.
Yeah, they're anterior and posterior. When do we do anterior?
في cystourethro seal, doctor.
Okay, and when do we do the posterior?
في الretroseal.
The rective seal. Rectum. R-E-C-T.
Yes, sir.
Okay, so the surgery for pelvic organ prolapse is generally called colporaphy. Colpo means vaginal. And رفي تعرف شو معنات رفي بالعربي؟
يعني دكتور زي الشبك أو شيء زي هيك؟ أو زي المنخل، زي المنخل؟
لا خلينا.
سوري.
هذاك اسمها بلاستيك، بس يخلص الأذان اللي عندك تحملني. Okay. هلا colpo means vaginal. رفي is a type of repair and surgery where you close a defect. زي بالhernia زي بأي شيء. So in general, when you plicate, we bring two. Let's presume. 1 second. Okay. So let's presume this is a facial plane. We have a defect in this area that's causing a cystocele. Of course, the defect is usually longer. So what we do is that we bring this part of the tissue and we suture it to this part so that this area of the defect will have two layers of fascia. بالعربي رفي معناتها رثاء، رثي زي الأواعي، كيف لما ترتي الأواعي مثل مخزوقة. That's رفي. When we use mesh, it's called plasty, and we never expect your students to know about colpoplasty. And usually we don't do colpoplasty anymore due to high rate of complications. So when we use artificial mesh to repair the defect, this mesh is usually monofilament, and we insert it on the defect, and this mesh will induce fibrosis later on to repair the defect. This is called colpoplasty. Colpoplasty is not done anymore. We only do colporaphy. Okay, so if the defect is anterior in cystocele, it's called anterior colporaphy. Also acceptable is anterior vaginal repair. If it's rectocele or anterior cele, it's called posterior vaginal repair or posterior colporaphy. Okay, these are equal names. The Americans prefer colpography. The English prefer posterior vaginal repair. Okay, so these are for vaginal prolapses. Let's presume we have a uterine prolapse. What can we do for uterine prolapse or apical prolapse? What are the treatments? I don't know what's happening. Bayan?
If the patient completed her family أو older age نعمل vaginal hysterectomy. وإذا not completed the family ممكن نعمل مانشستر. وفي كمان إذا complete the family and wish to conserve the uterus ممكن نعمل sacrohysterobixy.
So we have multiple solutions. They all depend on how fit our patient is for surgery. Do they like to conceive again? Of course, whenever you do surgery for any type of pelvic organ prolapse, you try to postpone it until the patient has actually completed her family. Because regardless of what type of surgery we do, if she wishes to conceive again and she delivers with her vaginal or cesarean section, this will increase the risk of failure of our surgeries, and we're going to have to repeat them. And whenever we repeat surgery at the same site, the second surgery is usually more difficult due to fibrosis and loss of anatomy. So in general, whenever we have uterine organ prolapse, if the patient completed her family and she's older and she does not wish to conserve her uterus, it's vaginal hysterectomy. If she does wish to conserve her uterus, it's sacrospinous hysteropixy. What does sacrospinous hysteropixy mean? Does anyone know? تفضل زواهرة.
دكتور بيعنوا في إنه الفاجينال فالوت suspension.
Okay, so from the name, it's sacrospinous, hystero, and pixie. What are we referring to by sacrospinous? Bayan?
الساكرال بون يعني.
No, that's the sacrospinous ligament.
Okay, yes.
Okay. Hystero. Hystero is referring to the uterus. And what does pixie mean whenever we say pixie in surgeries?
Fixation.
Yeah, fixation. We're trying to fix something else. So sacrospinous hysteropixy is trying to fix the uterus to the sacrospinous ligament. Otherwise, it's called sometimes sacrospinous fixation. This is a surgery usually done through the abdomen. Okay, and this is one type of surgeries we can do, although it's rarely done because it does cause some type of pain later on in life. But that's another solution we can do. So that's sacrospinous hysteropixy. You see the uterus is either sutured to the sacrospinous ligament, or more currently what they do is that they insert a mesh from the cervix and posterior uterine wall, and this mesh is Y-shaped and it attaches to both sacrospinous ligaments, and they suture it to the sacrospinous ligaments from the posterior wall. Imagine it's sort of like this. Okay. And what's the last solution if the patient's not fit for surgery and they have significant symptoms? We're trying to improve their quality of life. زواهرة كمان مرة.
الدكتور في شيء بيسموه الليفورت كولبو كليسز.
Colpodesis. Yes, Lefort colpoclesis. What's Lefort colpoclesis?
هم بسكروا جزء من الفاجينا يعني.
Yeah. You're closing the whole vaginal orifice. You're suturing the whole vaginal wall to each other. So what they do is that, let's presume that's the uterus, that's prolapsed, sort of like this. So they try to cut the mucosal surfaces of the anterior and posterior vaginal wall, and they suture the fascia to each other so that they close the whole space. So what's the problem in this case? Sometimes they can have problems urinating, and of course, there's no longer vaginal penetration whenever you do this. Okay, so these are the solutions for what we call apical prolapse or uterine prolapse. Any questions so far in regards to pelvic organ prolapses in general? Okay, so let's presume this lady does indeed, her primary complaint is urinary incontinence. What should we do? How would our management change? Does anyone have any suggestions? How would her management change? Let's presume we have the same lady. She's 83. She tells you I have a prolapsing vaginal mass. It's not bothering me quite much. I don't have pain, but I have loss of control over my urination. So what should I do? What should we do next? زواهرة؟
دكتور مش متأكد بس يعني we investigate the urinary symptoms ونشوف إذا في مثلا infection يعني current infection مثلا try to
يعني what would you do in her investigations?
بدنا نعمل urine analysis and urine culture.
Fair enough. We should do urine analysis and urine culture. Yes, that's always the first step in any type of urinary incontinence. Amr? Okay, I'll discuss this issue later on. Any other suggestions in regards to other tests we might do?
Yes, دكتور.
تفضل.
ممكن نعمل لهم biochemical testing يعني related للkidney function مثلا creatinine أو urea, something like that.
We don't have to go through it. So in general, in regards to urinary incontinence, the first step is trying by history to identify which type of incontinence. Is it stress? Is it urge? Is it mixed? If it's stress or urge, we consider it isolated. We go for urine analysis and culture to confirm there is no UTI predisposing her to her urinary incontinence. If there is no UTI, we can start by treatment. So how do we treat stress incontinence? زواهرة؟
دكتور بيستخدموا طبعا إذا كان في البرولابس بيعالجوا البرولابس زي ما حكينا. إذا في بيستخدم tension free vaginal tape, something like that.
قبل ما نروح للسيرجريز.
مش متأكد بالنسبة للconservative.
ليان تفضلي.
دكتور ممكن medical treatment زي drugs, I think anticholinergics, M3 receptor agonists.
We're talking about stress incontinence.
Okay.
دكتور ممكن toilet training؟
No. نفس اللي حكيناه بالpelvic organ prolapse. We try to stop anything that will increase the intra-abdominal pressure, whether it's cough, constipation, or obesity. And then you'll do pelvic floor exercises and you watch, did it improve or not? Let's presume it did not improve. What can we do? The ideal treatment next is surgery. The surgeries, we have two types of surgery. One is the one that Dr. Zawahiri talked about. The acronym is TVT-TO. TVT stands for tension-free. My mouse is causing trouble. Tension-free vaginal tape. The TO stands for trans obturator. Goes through the obturator membrane. So what that does is, let's presume you have a bladder. These are pubic bones here, and you have the obturator foramina on both sides. So usually the problem is that you have loss of angle in the bladder neck. So what they do is that they insert a mesh tape, it's made of polyester, just beneath the urethra, between the vaginal and the urethra, into both obturator membranes, and they suspend the bladder neck, and that's called TVT-TO. Is there another type of surgery, Layan? Do you have a question?
لا بس ممكن sling I think.
Me هاي one of the slings.
Okay, sorry.
زواهرة؟
دكتور في بسموه ال TOT اللي هو ال tension free operator tape.
هاي كلهم نفس الشيء. TVT TO أو TOT ممكن تكون retropubic يسموها sling and so on. They're all different types of the same surgery. You're all trying to do is to suspend the bladder neck. You can do it through the abdomen and insert a sling. You can do it through the vaginal wall and suspend this sling to the obturator membranes. You can even suspend it to the sacrospinous ligaments in older surgeries. There's something called purge, colpo, suspension. In purge colpo suspension, you're suspending the bladder neck to the sacrospinous ligament itself, not the urethra of the bladder neck. And that used to be the gold standard. And some do still consider it the gold standard for stress incontinence. Purge colpo suspension. CH. Okay. So let's presume the lady does not have stress. She has urge. What can we do? زواهرة؟
دكتور نفس الشيء بنشتغل على الاشياء اللي هي اللايف ستايل مثلا behavioral modification يعني
اللايف ستايل هون غير زي
اوكي
شو بدنا
يمكن تقلل من الكافيين والسموكينج مثلا
reduce caffeine, alcohol and smoking. شو كمان؟
ممكن بنحكي لها انه تترين herself to have يعني regular voiding يعني schedule خلال اليوم.
هذا إذا كل شيء مزبطش معنا.
اوكي.
شو ممكن نعمل شيء ثاني؟
وفي زي ما حكوا الفيزيوثيرابي الاكسرسايز بسموه كيجل.
Does not work in this case because the problem is not loss of tone in the pelvic musculature. The problem here is increased tone. Layan?
Anticholinergic drugs.
Okay, these are options, but before we step into medical treatment, is there anything else we can do? So in general, you do start with lifestyle modification by reducing any aggravating factors, anything that will increase the tone, such as caffeines, methylxanthines, alcohol. You also might ask her to reduce her fluid intakes at night so that she doesn't have to wake up in the first place. Sometimes we ask the patients to do what we call a bladder diary. In a bladder diary, the patient writes down everything she drank throughout the day and how many times did she go to the restroom, how much did she drink, how much did she void, and how much did she wake up at night to void in the first place, so that we try to alleviate these issues. If that fails, we go for medical treatment. Usually we start medical treatment with lifestyle modification in the first place in urgent incontinence. One of our options, yes indeed, as Layan said, is anticholinergics. Do you have options other than anticholinergics? to treat urgent continence.
يس دكتور، مرات تستخدموا types of antidepressant tricyclic ممكن.
Tricyclics for nocturnal enuresis. It's not for urgent continence, although it does have a mild anticholinergic effect, and that's why it's contraindicated in bladder outlet obstruction. But it's not indicated for treating urgent continence. Liam?
ممكن alpha blockers.
What do we use alpha blockers for? We don't use it in females, by the way. It's only in males. Why do they use it in males for?
ممكن topical estrogen.
Topical estrogen is for all your genital complaints in menopause. But it's not specific to any treatment, and it does not really help much in urge. Okay, so in general, if you remember from your physiology, if we draw a bladder, the bladder has a neck and has a dome. The detrosal muscle has two types of receptors, beta 3 and muscarinic. And the neck has alpha. Anticholinergics work on muscarinic. We have beta 3 blockers. Alpha constricts the sphincter. So whenever we have a problem with the bladder neck, we can use alpha blockers. That's in benign prostatic hyperplasia, not in females. But usually the first choice is muscarinic in urgent continence. The names, although I doubt you'll need to remember them, is oxybutynin, tolterenine. These are muscarinic, anti-muscarinic. And in regards to beta blocker, we only have one drug. It's called Mira. So these are the medical treatments. Let's presume we start a medical treatment, the patient is not improving. What should we do? Any suggestions? Usually then, if the patient does not improve after first treatment, we go for something called urodynamic study. Okay, UDS. Would anyone care to tell us what urodynamic studies are? زهرة؟
يس دكتور، ستست يعني بيعملوا فيه بيقيسوا البريشر، يمكن يجوا الابدومين والبلادر، يعني something like that.
Okay. Any other suggestions? What are urodynamic studies? ثواني دكتور لكم صورة. لا مش عارف. سماح؟ اوكي. فين الشاشة هاي صح؟
دكتور احنا
اوكي تفضل احكي.
يعني ما بعرف، حضرتها انا مرة يعني على مريض انه كانوا بيشربوه ليكويد بكميات معينة، فعني بيكون assistant with X-ray، لا مش X-ray، HCG I think with contrast. الفكرة إنهم بيعطوه amount of fluid. They try to know كم capability of that bladder or amount, or at which amount he will start feel the urge to urinate.
So let me put it in other words. So in urodynamic studies, I'm going to stop the sharing and switch it for a moment. Just give me a moment. Stop sharing. Share content. I'm going to switch the screens. زيادة شكل الماوس. Second screen. Okay. So that's a diagram of urodynamic studies. So in urodynamic studies, they first try to inflate the bladder. Whenever the bladder is full, they measure the three main pressures. The physical pressure. The physical pressure is the pressure within the bladder itself, within the cavity of the bladder. They measure the abdominal pressure, and they measure which is the pressure of the trozal muscle, not the bladder, the volume within the bladder muscle itself. Okay. First, after they fill it, they observe what changes, and according to these changes, the leak of urine, the incontinence there is. So let's take this example. Here we have the vesical pressure suddenly spiked. It was associated with increased abdominal pressure and leakage of urine. What type of incontinence is it? By common sense, it's quite easy to understand urodynamic studies.
Stress, doctor.
Yeah, stress incontinence. You have increasing abdominal pressure that caused increasing vesical pressure. The trozal pressure was almost flat. There's no changes. So it's third, this is stress. Of course, more than one of these occur. So this is the actual one. So if you see you're filling the bladder, you always observe how the increasing pressure within the blood go. It should not be more than 20. It should be in this line here. If it's more, that means there is lack of compliance within the bladder, but you will never be asked about these issues. So this lady, if you see here, she has these contractions. If she had leakage of urine in these points, what type of incontinence does she have? This is B. DET means the trozal. ABD abdominal. VES means vesical.
دكتور إذا كانت في الديتروزال ماسل يعني في مشكلة بالأكتيفيتي بده يكون urge incontinence إذا طلع بالgreen one.
So whenever urge incontinence is confirmed on urodynamic study, بصير اسمه the trozal instability because it's confirmed. It's not clinical. It's investigative diagnosis. أحيانا بيزنخوا عليكم هيك بالامتحان. So whenever urge incontinence is confirmed on urodynamic study, بصير اسمه urodynamic instability or the trozal instability. Sorry. So again, normally the patient should not have any leakage of urine in any circumstance. If she leaks with any of the maneuvers that increase intra-abdominal pressure, that's stress incontinence. If she leaks with increased the trozal pressure, that means that's urodynamic incontinence. And then they ask the patient to void and they observe how the pressure changes in the body. You just need to differentiate between stress and urodynamic instability because sometimes you have these questions in your mini OSCE exam. So again, there are three main pressures. They're not only three, but these are the ones that you need to know. The trozal, abdominal, and vesical. And then you observe the urine flow. If there is any leakage of urine with increased the trozal pressure, isolated increase in the trozal pressure, that means this is the trozal instability. If there is leakage of urine with increased abdominal pressure, there is stress incontinence. They can coexist with each other. Of course, any increased abdominal pressure or the trozal pressure will also increase the vesical pressure because that's the total pressure within the bladder itself. And it's affected by both the abdomen and the bladder muscle itself. What else you guys should know about urodynamic studies are these numbers. Of course, we have a lecture about urodynamic studies about urinary stress incontinence, pelvic organ prolapses. Memorize those numbers because these are the ones you'll be asked about exam. But in general, the urine flow should be more than 15 milliliters per second. If it's less, that means there is bladder obstruction or atonic bladder. The bladder capacity should be always more than 300, and the first sensation to void should be more than 200. The residual, which is detected usually on ultrasound, beta-3 blockers. If those fail, we have other interventions. They're slightly beyond your scope. We can do cystoplasty by modifying the volume of the bladder. Currently, there is something we call sacral nerve stimulation or common perineal nerve stimulation. What they do is that there is a device that's put on the ankle. It has a battery. It gives certain electrical shocks. Usually, the patient receives one session per week for 6 to 12 weeks. And by neuromodulation, it will reduce urgent incontinence. If that all fails, do we have other solutions to control urgent incontinence? There's something that is called intravezical Partoxin injections. So you know Botox? We inject it within the bladder muscle to try to relax it. Usually that works. For stress incontinence, sometimes we can also use bulking agents that we inject around the urethra to narrow the urethra so that we avoid beyond your scope. So we're done for today. Do you have any questions? Does anyone have any questions in regards to pelvic organ prolapses and urogynecology in general? Okay, so we're done for today. I hope you all have a good rest of your days, and see you later. Bye bye. I think.